Hi, I am Catalina Navarro, one of the TV nurse consultants at Heartland National TB Center. And I am here today with Dr. Lisa Armitage. She's one of the TB experts at Heartland. She's also a pediatrician internist and an infectious disease doctor. And she's here today to share with us the most recent updates from this book, the American Academy of Pediatrics Redbook, with the new updates regarding TB and pediatrics.
There are some changes in not only diagnosis of tuberculosis and TB infection in children, but also dosing for our one of our treatment regimen, one of the drugs that's important in our treatment regimen, and then also the availability of another treatment option for younger children with TB infection and not disease.
Mm-hmm. Are there any changes in the treatment for latent TB infection?
So for TB infection, for years we had basically two options. We had isoniazid, which the CDC always listed as the preferred regimen. But isoniazid takes a really long time to treat, and it also is a drug that most children don't finish. It takes a long time. 9 months is a long time to ask a parent to give a child a drug. And also for the health departments, it's a long time for them to have to deliver directly observed therapy. So one of the regimens that's gotten to be more popular is the new 3HP regimen. But we only had recommendations to use it down to age 12. Children who were younger than that, it was a case-by-case basis. Now we have firm data that shows that the 3HP is safe in children down to 2 years of age. Mm-hmm. So there was always a recommendation for how to dose rifapentine, but now we have the correct dosing, and we also have the recommendation that we can use 3HP in children down to age 2.
Okay, and the doses are the same, the INH and the rifapentine?
So the doses for rifapentine are the same. If you looked at the old table had doses that went all the way down to 22 pounds or 10 kilograms. Mm-hmm. The dose for isoniazid, though, it's good that you ask. It's a slightly different. It's a little higher. So the recommended dose for children age 12 and up to adulthood, that dose is 15 milligrams per kilogram for isoniazid, whereas opposed to children who are ages 2 to 11, that dose is 25 milligrams per kilogram. So increased over that. But it's still maxes out at 900. 900 is still the max dose. So if you have some children who are larger children, when you dose, you never go over the 900. Mm-hmm. But it is slightly higher for the isoniazid dose in that group.
Okay. Regarding the TB screening for children, we have been using the tuberculin skin test forever.
Right.
There is
so,
changes.
Always with children who are BCG vaccinated, we always had the children who were younger and more recently BCG vaccinated, you're always more concerned that the skin test may be false positive. Now, there's data to say we can use the IGRAs all the way down to age 2. Younger than 2 years old, the test is still not the data is not as clean. We just don't have as much information. But down to age 2, that is a test that is good for determining infection with Mycobacterium tuberculosis. So it is now, the guidelines are very similar to what you had for children ages 5 years and older. You should not be testing anyone who is not high risk. So if it has been determined that the child needs testing, you can use an IGRA down to 2. And also, any child who is BCG vaccinated or is unlikely to return, just as it is in adults, that is the preferred test, is the IGRA. So that was a big difference that we can use down to age 2.
Okay. I was reading the book about for treatment of tuberculosis, the doses of rifampin.
Yeah, the doses of rifampin have changed significantly this year. So the old dosing range was 10 milligrams to 20 milligrams per kilogram of rifampin per day for a child. Now, and also even in the intermittent dosing, that was the dose. Now the dose is increased. We figured out that 10 milligrams per kilogram is probably a little bit on the low side. The range now is 15 to 20 milligrams per kilogram. It's a little narrower, but you want to go at the higher end of the old range. So the new dosing recommendation is 15 to 20 milligrams per kilogram of rifampin for children, for children, any children of any age up to age 17. Now, that range of treatment is even probably a little bit too low for the very smallest children. The very smallest children, ages birth to about 2 years of age. Mm-hmm. So as it's written, it says infants and toddlers, really up until about age 2. The range for those children is 20 milligrams to 30 milligrams per kilogram. So significantly higher. So just, to be aware that the correct dosing range is a little higher. Now, in addition, any child who has, say, disseminated disease, but especially children, even adults who have meningitis, is recommended that highest range, that 20 to 30 milligrams per kilogram, be strongly considered, because you really want to get good killing across the blood-brain barrier.
It's almost double the dose.
It's almost double the old dose, yes.
And how about side effects? Is there any problem with side effects?
So there's a question, with increasing the dose, are you going to increase the risk of side effects? Children tend to tolerate the TV meds very well. There isn't a history of, they haven't really done a lot of, use their organs a whole lot. So they're very good at metabolizing drugs and having drugs, that clear the system very quickly. That's why it's important to get the doses higher, so you actually achieve the range that you need to help the child cure. So side effects have not been a problem.
Dr. Armitage, what do you think that these changes are going to impact the treatment of children
with tuberculosis? So the nice thing about the current updates is we have a few changes from diagnosis all the way through treatment of TB infection, all the way through, treatment of TB disease. So now, we have a test. It was always a little concerning when you did a skin test on a child who's less than 5. If they've been BCG vaccinated, that is the group that is most likely to have a false positive. So we were treating a good number of children that we really honestly felt likely had not been infected. But because TB is such an aggressive disease in children who are less than 5, we did treat. So when the IGRAs went down to 5, this was a great day, because now we have children who are 5 years and older who we were not having to treat for false positive tests. If they could come in, they could have an IGRA, and then we would know if they are actually infected rather than have a skin test and guess. Now we're taking that age all the way down to 2 years of age. So now we're getting some of our littlest patients from ages 2 to age 5 that we weren't getting before. Now we're able to say, well, confidently, we can do a test with an IGRA, and we can know that child isn't, if they are infected, we're going to treat them. We're going to treat them for TB infection, and we're going to make sure that they stay safe. But we also know confidently if the test is negative, that they have tested negative and there's no need for further intervention. Then we can just, tell the parents, your child has a false positive TST. Make sure if you have to test them for school, if you have to test them for camp, or if you have to test them to participate in any activity, that they do an IGRA, because, your child is not infected. This is really important because a lot of our cases now are more associated with foreign-born individuals. So most of the children we're screening, either they were born in Mexico and they're immigrating, or they were born in Mexico and were exposed to someone who are, Mexico for us in Texas, but foreign-born individuals coming from all over the planet. And so we have now a test that we can keep kids safe, that we don't have to do as much testing. Now, increasing the doses of rifampin, that is a really big thing. To understand that we've been perhaps underdosing. Children tend to do well. They just, with the medications, they do well. You give them the medication and their urine will turn red just like everyone else's will. But that's about the only side effect. They don't tend to have so many, different side effects that people who have, as I say, 20 years of drinking and smoking and chicken fried steak eating, they don't have all of that, so their organs tend to break down the meds very efficiently. Knowing that we're getting in a good range and that we're curing our children with the best efficiency, everybody feels a lot better with that. So now the 3HP, that's a big thing. If I have to go in a house and I have everyone, from the mother, the father, the older siblings, they're all on 3HP, they get a once a week dosing. But we're having to dose that child every single day. Everybody knows it's a little bit more complicated with children. If you have to, you get into a rhythm with them, but every day we would love to have something where the child is treated with directly observed therapy. Or even if we have a parent who is highly motivated and self-administered therapy is an option. We only have to sit down and get the pills into the baby once a week. And, the experience that we've had, the pills are a little bitter, so you may want to work a little harder at masking them, the rifabutin. But if you dissolve those in a little bit of warm water, the pills will go into solution. You can mix it into any kind of yumminess, and then the child can have a once a week dosing just like the rest of the family. And in 12 weeks, we're all done. So a lot less dosing, a lot less, of having to, stress. If you're a parent and you're having to give your baby medicines every day, you'll do it. You want to keep them safe and you want to keep them protected. But if you could do 12 doses in a child, just like you do 12 doses in the parent, and know that the child will be effectively treated, that's a really big gain. So a lot of it is just, knowing that we're doing better by our smallest patients. We're still, not able to make a lot of changes in children who are under 2 years of age. We're still kind of, the skin test is still our test of record, and still 3HP, those little kidneys and livers are breaking down that medication in all kind of different ways. So we're not quite there yet with our littlest patients, but we have gotten all the way down to age 2, where those of us who remember when we were doing the skin test, when that's all we had, we were doing skin tests on folks all the way up to probably 20% of them were having false positive skin tests, and that was a whole lot more treatment. Big gain down to 5, but even bigger gain down to our smallest children. So we're making some progress in pediatrics, and we've had a lot of good things come of the changes this year.
Okay. Thank you so much, Dr. Armitage, for sharing with us these updates, and thank you to you all for watching this video. Have a good day.